All right, so part 2 of the patient assessment video, we're going to pick up with history taking. Now, with history taking, this is information you're going to gather on basically every patient that you come into contact with. And so these are questions that you may be asking the patient, maybe asking a family member, a caregiver, parent. It really just depends on the situation. And it might determine when you're going to ask these questions. If it's a medical patient, you might ask them a little sooner. If it's a trauma patient, you might ask them on the way to the hospital. So it depends on what's going on with you as well. But the basic history that we need for every patient is going to be sample. All right, and so sample stands for signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and the events leading up to what happened today. So we need to know the difference between signs and symptoms. A sign you physically see, like vomiting. A symptom, the patient tells you that they feel, like nausea. Okay, allergies is the patient allergic to anything, not just medications, but food, animals, anything at all that could be, especially if you think that that could be contributing to what's going on here today. Could it be an allergic reaction? Medications, so what medications do you take daily? And then what medications are you supposed to take daily? So not only that, what do you take, but are you supposed to take something that you don't for whatever reason? Can't afford it, just general non-compliance, don't feel like you need it, forget to take it, whatever it is. And then have you taken any medications for what's going on today related to this specific complaint? All very important. We also want to ask about the medical history, so pertinent meaning that it's relevant to what's going on today, but you want to make sure you're asking a good medical history and that you're kind of weeding that out for yourself. So don't tell the patient, like, no, that's not important, but you know in your mind that if the patient is having chest pain, then their ingrown toenail removal really doesn't matter related to that. But if the patient has had a heart attack, or they've had abdominal surgeries, or they have difficulty breathing, and they have like COPD or emphysema, those things do matter when we're talking about the pertinent past medical history. So just look at what the patient is complaining of. We're going to ask them about their last oral intake. Again, could that be what's contributing to what's happening here? Is it irritating, food poisoning, allergic reaction? And then the events leading up to. So what was going on with the patient when the pain or symptoms started? Were they at rest? Did it wake them up from sleep? Were they physically exerting themselves? So all of these very important factors when we're getting this history. Now that's going to bring us down to the secondary assessment. This is where it gets really important. So there are 2 types of secondary assessments. And so one of those is a full body rapid trauma assessment. The other one is a focus, or you can call this a medical assessment. All right. And so every type of patient will fall into one of these 2 categories, and we need to make sure we know which one. So if the patient has a significant mechanism of injury or is unconscious for any reason, they're going to receive that full body assessment. That means that we're going to put hands on every body part until we figure out what is going on. All right. If we're talking about significance, that means that it was a major injury, so potential for spinal trauma, major motor vehicle accidents, falls from twice their height or more, things like that. And this is, again, where we're going to be looking at the entire body for what we're going to term DCAP, BTLS, as well as site-specific injuries. When you do a focused or a medical assessment, this could be for a patient with a non-significant traumatic injury, just like a simple fall. They didn't get dizzy or anything, no injury to the head, neck, back, nothing like that. So a simple injury, or anybody with a medical related complaint. And here we're going to use more of an OPQRST evaluation, which we'll get to in just a second. So if we're going to be doing the full body assessment, what we're looking for at every portion of the body is termed DCAP BTLS, and that stands for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. And I gave you some picture examples of those in the full PowerPoint, so you can go and look at them if you're not familiar with these terms. Also giving you some more commonly used terms that go along with this, other names that we can use. But DCAP BTLS is what we're looking for in this full assessment. Wow, we're also looking for some site-specific injuries, okay? So if we're starting at the patient's head here, remember we've already done our primary assessment, so we already did our rapid scan for life-threatening bleeding. We already looked at the patient's circulation, their airway, their breathing. We addressed any life threats that we found. The purpose of this secondary assessment is to identify anything that we did not initially find when we were scanning that patient over. So here we're going to palpate the patient's scalp with the palm palms of your hands only, not your fingertips, because you don't want any type of crepitus, which is bone on bone fragments to go into the brain, or put your finger accidentally into brain tissue. So palms only when you're palpating or touching the scalp. Now, when you're coming down to the face, you are going to use your fingertips here as you palpate across the bony portions of the face, and you're feeling for any crepitus or that bone-on-bone feeling. You're also going to be looking at the eyes to see if there's any bruising around the eyes. We call that raccoon eyes. And you're going to be checking the pupillary status. And the mnemonic we use for pupils is PEARL. And that means pupils equal and round, reactive to light. So that's what we're going to be doing. And we'll talk more about how to exactly check pupils in the vital signs PowerPoint, but this is just to introduce you to that term and let you know that's what we're looking for here. So as we continue on with the head, we're going to start looking at the individual areas. At the ears, we're looking for blood, cerebrospinal fluid. We're also looking for bruising behind the ears called battle signs. It's difficult to know if there's any cerebrospinal fluid mixed in with the blood, and the way that we can tell that is by taking a piece of clean gauze and dipping it into that blood. And if we see that separation of cerebrospinal fluid around the blood, we call that the halo test. And so that's a good way to know that that's actually cerebrospinal fluid leaking out. Same thing can be done there at the nose. We're also looking for stability of the nose and septal deviation. And then at the mouth, you should have already assessed the airway here to make sure the airway is open and patent. But here you can also check for any specific injuries to the mouth, any blood, broken teeth, vomit, and also unusual odors like fruity odors or the scent of alcohol. Moving down from there, you're going to look at the neck. And so here you're going to look for any decap BTLS, also looking for any jugular vein distension, which is what you see listed in this picture here. So yes, even on a normal person, you should be able to see their vein to a certain extent, maybe depending on their size, if they turn their head or if they cough, but it should not be prominently sticking out like that unless blood is beginning to back up inside of the heart. Tracheal deviation, going to be that trachea should be midline in the front of the neck. So if it's not and it is moved to one side or the other, that should be a really good indicator to you that the patient has got air or something building up inside of the chest. And so pressure is causing that to move over and push on the uninjured lung, moving the trachea with it. We can also look for medical identification necklace here and also palpate the neck for any tenderness to the cervical spine. If the patient did have the potential for spinal injury, this would be the time to go ahead and fit that C-collar and place it on the patient as well. As we move down to the chest, here at the chest wall, we're looking for decap BTLS. We're also looking for equal chest rise and fall, and we can listen to lung sounds. If this is a male patient, it would be appropriate to palpate all portions of the chest wall with simply your palm, but in a female patient, it might be more appropriate to palpate with the side of your hand down the sternum and then palpate above and below the breast tissue. If you need to palpate it because of injury, then certainly do so, but it's just difficult to feel anything, especially if the patient does have larger breasts. So we just want to avoid unnecessary touching, but certainly if there's an injury there, you need to do that. As we move down to the abdomen, the first thing that you want to do if the patient is conscious or able to answer questions, you want to ask them, are they having any pain? And if so, we're going to identify where it's at, and we're going to start that abdominal assessment furthest away from that pain. If they're unconscious or do not have any pain, you can start wherever you want to. And remember, we're imagining breaking this down into quadrants, or those imaginary lines, and we're checking those quadrants as we're palpating or touching for rigidity, tenderness, rebound tenderness, and distension. So is it raised when it's not supposed to? Is it tender or painful for us to touch? Rebound tenderness means that it hurts more when we let go. So the pain actually feels better when you push in, and it hurts more when you let go. And that's actually a really indicative sign of appendicitis. If you have relief of pain when palpating the right lower quadrant, and then an increase in pain when you let that go. So we can move down here from the abdominal area and just reach our hands around. So we're not completely rolling our patient over yet, but just reaching our hands around to assess that lower lumbar area for any type of deformities or pain when we palpate. And then we can move down to the pelvis. So same thing that we did with the abdominal section. If the patient has any pain here, we do not want to palpate, because what we don't want is if there are any bone fragments, to sever any of those large arteries or blood vessels that are inside of that pelvic cavity. So if they have pelvic pain, then we want to just proceed on and not palpate. But if the patient is unresponsive or they do not have any pain, then we're going to put our hands on the wings of the pelvis, the meaty portion around our thumb on the wings of the pelvis, and wrap our hands down, and you'll see that in my video. And we're going to press in and down just one time, but not rock back and forth on the pelvis. We should never do that. We're also going to be assessing here for urinary or fecal incontinence, like maybe if the patient passed out or they had a seizure, they've had a loss of that bowel or bladder. And we can also use the back of the hand to sweep for a priapism, which would be an unwanted or unintentional erection in a male patient that comes from a spinal cord injury. So you can sweep for that with the back of the hand as well. From here, we would move down to the lower extremities, and so not only are we going to move down and look for decap BTLS down the entire both legs, but we're also going to take this opportunity to assess pulse, motor function, and sensation, or PMS. And so we want to do that at the same time so that we can compare one side to the other and see if there is any type of weakness here. And so basically you're going to check the pulses and make sure that they're equal. And you can do that where they're touching in this picture on top of the foot, but also on the posterior tibial artery behind the inside of the ankle. And so you could check the pulse in one of those spots. And then also, do you feel me touching you? And can you push or pull against my hands? We're also going to be moving here up to the upper extremities. And remember, upper extremities are last because they're least life-threatening than those large potential injuries and arteries there in the lower extremities. And so same thing, decap BTLS down both arms and checking PMS at the same time to compare them in both arms. So checking that radial pulse, and then can you feel me touching you? Can you squeeze my fingers? And we could have also looked for any medical identification on the lower extremities as well as the upper extremities. Most people generally have that emergency information in their cell phones these days and not so much of medical identification bracelets or tags, but we can still take the opportunity to look. Now we're going to log roll the patient over onto their side, and so now we're going to take this opportunity to look at the back of the patient, and we're going to palpate down the spinal column. So not only are we looking for decap BTLS, but we're going to be palpating down each vertebra of the spine to feel and see if there's any step off, if anything's sticking out where it shouldn't be, if there's pain with palpation, and we can also listen to lung sounds on the back as well. And then if this patient was going to be put onto a backboard, we would take this opportunity now to log roll them back onto the backboard, whether we're going to move them with it or whether we're going to be able to completely immobilize the spine. We would do that at this point. Now, if this is where we're at, then we're done with that full body or rapid trauma assessment. And even though it took me a few minutes to talk about this, it might not take you so long once you get in the habit of doing it out in the field, okay? So we don't want to delay transport. This can be done in the back of the truck en route to the hospital. So don't ever delay transport for that if this is a time where we need to be off the scene in less than 10 minutes to be within that golden hour. But if you have time to do it on scene, then certainly you can. So it really just is going to be kind of dependent on what's going on with your patient. So from here, I'm going to stop this portion of the video now, and I'll pick back up in another part in talking about the medical assessment.